This video will cover the definitions, etiology, pathophysiology, clinical features, risk factors, evaluation, diagnoses, treatment, and complications of tetanus and botulism. Tetanus is an infection caused by a powerful neurotoxin from Clostridium tetani. It is characterized by muscle spasms, lockjaw or trismus, and generalized hypertonia, particularly in the jaw and neck. This disease mainly affects unvaccinated individuals or elderly patients with decreased immunity. The global incidence has decreased due to vaccination campaigns. Spasms can last for minutes to weeks, often starting in the face and moving down the body. Tetanus is classified as generalized, neonatal, localized, or cerebral. Tetanus is caused by the bacterium Clostridium tetani, a gram-positive spore-forming bacteria found in soil, dust, or animal feces. It can enter the body through wound punctures, lacerations, skin breaks, or contaminated syringes or insect bites. Risk factors for neonatal tetanus include an unvaccinated mother, septic cutting of the umbilical cord, and applying infectious substances like animal dung or mud to the umbilical stump. Other general risk factors include burns, animal bites, war wounds, or unsterile surgeries. C. tetani secretes two toxins, Tetanospasmin, which is neurotoxic, and tetanolysin, a hemolytic toxin. Tetanus spores enter the wound and germinate under anaerobic conditions, such as in dead tissue. Tetanospasmin is then released into the bloodstream. The toxin enters the presynaptic terminals of motor neurons, inactivating inhibitory neurotransmission that normally suppresses muscle activity. This action initially paralyzes muscle fibers. The toxin then travels to the central nervous system via retrograde axonal transport, inhibiting inhibitory neurotransmitter release, such as GABA. This prevents the inhibition of motor reflex responses, leading to tetanic spasms, which can be severe enough to cause bone fractures and muscle tears. Autonomic dysfunction occurs after the neurotoxin enters the brainstem, usually in the second week. Patients may experience labile blood pressure and heart rate, diaphoresis, bradyarrhythmias, and potentially cardiac arrest. Symptoms can persist for weeks to months. Clinical features include lockjaw, a grimace facial expression called rhesus sardonicus, severe generalized muscle spasms, drooling, uncontrolled urination and defecation, and back-arching spasm, or opisthetonis, which can cause respiratory distress. Diagnosis involves wound culture to isolate the organism and a history of injury. The spatula test, where touching the posterior pharyngeal wall elicits an involuntary jaw contraction instead of a gag reflex, suggests a positive result. Treatment includes early wound debridement, supportive management, and antibiotic therapy. Early administration of human tetanus immunoglobulin, neuromuscular blockade, and managing complications are also key. First-line treatment is human tetanus immunoglobulin, typically a 500 U dose, which removes released tetanospasmin but does not affect the toxin already bound to the central nervous system. Metronidazole has been shown to slow disease progression. Other treatments include penicillin and antispasmodics, like benzodiazepines and baclofen. Mechanical ventilation and tracheostomy may be required, especially if intubation is needed for more than 10 days, as endotracheal tubes can stimulate muscle spasms. Next, we will discuss botulism. Botulism is a rare, life-threatening paralytic illness. It is caused by a neurotoxin from the bacterium Clostridium botulinum. The toxin interferes with the nervous system, causing muscle weakness, paralysis, and potentially respiratory failure and death. The toxin is produced by the anaerobic bacteria Clostridium botulinum and sometimes Clostridium butyricum and Clostridium baratii. These bacteria form protective spores and can produce the toxin in food, wounds, and infants' intestines. Bacterial spores are highly resilient, but usually do not cause illness when ingested. However, under specific conditions, anaerobic environment, low acid, low sugar, low salt, a certain temperature range, and water amount, these spores can grow and produce the lethal toxin. In infant botulism, C. botulinum colonizes the digestive tract or bronchioles after ingestion or inhalation of spores, releasing toxins into the circulation. Food-borne botulism results from ingesting preformed toxin in improperly stored food, which is absorbed in the intestinal tract. Wound botulism occurs when spores germinate in devitalized tissue, releasing botulinum neurotoxin into the local circulation. Once in the bloodstream, the neurotoxin binds to presynaptic nerve terminals, blocking acetylcholine release and inhibiting muscle contraction, leading to flaccid paralysis. Signs and symptoms include difficulty swallowing, muscle weakness, double and blurry vision, drooping eyelids, and slurred speech. Other symptoms are difficulty breathing and moving the eyes, along with vomiting, nausea, stomach pain, and diarrhea. Diagnosis involves laboratory confirmation using serum and stool assays for the botulinum neurotoxin, stool microscopy for spores, and stool cultures. Wound cultures are used in the case of wound botulism. Treatment includes botulinum toxin type A antitoxin and aggressive supportive care in an ICU. Monitoring the airway is crucial due to the risk of respiratory failure. Intubation is required with the slightest hint of respiratory distress, and some patients need a tracheostomy. Antibiotic treatments include penicillin G intravenously every 4 hours, or metronidazole for penicillin-allergic patients. Vital signs, oxygenation, and arterial blood gases must be closely monitored. Here are the references used in creating this video. Thank you for watching this video.